Everyone, my name is Jonathon Lumley, and today I will be presenting my thesis proposal on the implementation of polymer gel dosimeters for clinical application. I would like to start off by thanking my project supervisors, Dr. Pejman, Rowshanfarzad, and Professor David Henry, along with all those behind the scenes who have helped me so far. So today we're going to begin on the topic of dosimetry. So what is dosimetry? It is the measurement of dosage of radiation that is absorbed by material, which in our case, in radiotherapy, is often human tissue. This is conducted using an instrument which we creatively refer to as a dosimeter. There are many different types of dosimeters out there for treatment verification, such as ionization chamber-based dosimeters and radiographic film-based dosimeters. So, as clinical therapy advances, there are many new techniques, such as VEMA and stereotactic surgery, which are growing in complexity. The need for high precision and accuracy in these modern day techniques means that any errors, both dosimetric and geometric in nature, can lead to undesirable results. So you might be thinking to yourself, well, John, you just said that we have these dosimeters such as ion chambers in film. Why can't we just use those? Well, to be able to provide the highest accuracy, we need a dosimeter that can properly represent and describe the dose distribution in and around the tumor. So ion chambers and film dosimeters can only measure dose distributions in one dimension and two dimensions, respectively. However, since I last checked, we live in a three-dimensional world, meaning that to properly capture the distribution, we need a dosimeter that can truly measure dose distribution in 3 dimensions. One such example of this is polymer gel dosimeters. So what is a polymer gel dosimeter? A polymer gel dosimeter is a dosimeter which is comprised of many different chemical constituents, such as monomers, which upon irradiation undergo dose-dependent polymerization through a process known as radiolysis. This polymerization is able to capture both geometric and dosimetric information based on the location and magnitude of the polymerization within the gel, respectively. So if we look at figure 1, we can see that this is a non-uniformly rated polymer gel dosimeter. We can see that the white parts are the bits that have been irradiated, and that's the polymer actually precipitated out. And we can use that to both gather information on geometric and dosimetric information. So the radiation-induced polymerized molecules, have altered properties compared to their monomer counterparts. This can be exploited through many different various imaging modalities, such as magnetic resonance imaging, X-ray computer tomography, optical computer tomography, and ultrasound. So the majority of PG dosimeters consists of 4 main components: the monomers, the cross-linkers, the gelatin, and water. All of these serve various important roles within the dosimeter. Dosimeters using these components were first implemented and developed by Muransky in 1994. However, it was noted that they were highly susceptible to oxygen, as it led to the creation of peroxide radicals. And these peroxide radicals actually lead to the termination of the polymerization reaction. This leads to an inaccurate representation of the dose delivered. So there are 2 main ways to remove this oxygen. The first method is if we make the gel in an oxygen-free environment. This is called an oxygen gel. However, this method, it can be quite complicated and requires equipment and experience that isn't typically seen outside of a chemistry laboratory. The second method, which is far, far easier, is if we just add antioxidants to the gel mixture. These will scavenge up the oxygen, and we refer to these as pneumoxic gels. So why polymer gel dosimeters? Why should we use these? Well, if we want to implement the hospital, we have to have a dosimeter that can show 3D representation. And the 3D representation is often limited with other dosimeters. This is especially true in small fields. So for example, if I take 2D film and stack them on top of each other, we can potentially lose information in between the finite spaces of the that are seen in the stacking of the film. Furthermore, due to the polymer dosimeters being made of approximately 90 to 80%, 80 to 90% water, they are tissue and water equivalent. This means that there is no conversion required between the material of the dosimeter and tissue. This removes any source of potential errors that could have come about during conversion. Another significant benefit that sets these dosimeters apart from other conventional dosimeters is that they can be molded and shaped into the patient's anatomy with contours and everything. This would further increase the accuracy when compared to as if we pretend the patient is a piece of film. If we compare these gel dosimeters to other gel dosimeters, such as Frickle-based gel dosimeters, we notice that polymer gel dosimeters do not suffer from high spatial instabilities relative to that set of Frickle gels. Furthermore, since there are no ferrous electrical components in the dosimeter, they are capable with new MRI LINAC technologies that are currently rolling out. And finally, since we can use the dosimeters to simulate both patient setup, irradiation, and imaging, we can actually use them to do full end-to-end testing on equipment, which would be very beneficial. So therefore, we can see from the PG dosimeters that they offer quite unique benefits, which could be exploited if implemented in a clinical setting. And this is what leads to my project. So my project is a continuation of a current research project conducted by Ban and Prip, and where we aim to implement and create a background to implement PG dosimeters into Sir Charles Gairdner Hospital, so they can be used for various clinical applications. This will be done through a series of objectives, which will be progressed through individually throughout the course of the project. These objectives will be set out into selection of the PG dosimeter, optimization of the PG dosimeter, creation of a detailed procedure for fabrication, and finally to establish a mini laboratory through recommendations made. And hopefully throughout all of these objectives, these will lead to the implementation of clinical dosimeters, gel dosimeters. So the first objective. The first objective will be to choose a polymer gel composition that will be most beneficial for the workload carried out in hospital. However, currently, to say there's a lot of variation in polymer gel compositions, and saying that there's a lot would be quite an understatement. The variation in the PG dosimeters in literature, combined with all the individual workflows for production, composition, tweaks, and evaluations, has led to a mountain of different PG dosimeters to choose from, all with different pros and cons to each other. For this reason, there is currently no gold standard in PG dosimetry. So a comprehensive lit review will be carried out to allow direct comparison of these different compositions, allowing for us to base a choice of PG dosimeter on characteristics which would be most suitable within the clinical environment. These characteristics will include low to no toxicity, good temporal and temperature stability, a good dose resolution, and high sensitivity. Once we have our dosimeter, we'll move on to objective 2, the ratio optimization of the gel dosimeter. So once we have selected our dosimeter, next objective would be to optimize it. Generally, PG dosimeters follow guidelines of 6% T to 50% C ratios, where %T is the total monomer mass to a total gel mass ratio, and % C is the cross-linker mass to total comonomer mass ratio. So for example, if we look at figure 2, the typical polyacrylamide gel dosimeter recipes, we see there's a 3% rate-to-rate ratio of both monomer and cross-linker, 5% rate-to-rate ratio in gelatin, and 89% in water. So through research, it's actually been found that if we change the components and the ratios, we can actually modify the gel response of the dosimeter. So for example, increase in the %T ratio has actually led to an increase in polymer gel sensitivity. If we look at figures 3 and 4, we will see that the AMP salt, which is the monomer of the passage dosimeter, along with the cross-linker bis,
Yeah, I spoke to Jane, and she replied that Megan has not yet created a plan.
Sorry.
Just continue, John.
Okay, sorry. Yeah, so 3, and then if we compare that to the ones where they have 4% increase, we see that there is actually an increase in the slope. And this increase in slope actually indicates an increase in sensitivity for the R2 dose curves. So after we do optimization, so the process of optimization, our procedure will be to fabricate PG dosimeters using various monomers and cross-linkers. And then we will have to store them in the fridge. After that, we will be irradiating them using the true beam linear accelerators at the hospital. And then, unfortunately, have to do more storage. After that, we will image them using MRI and hopefully other imaging modalities if time permits. And then after that, we will obtain dose response curves of the dosimeters to determine the sensitivity of each slope, because that could be used to compare them to see which ones which benefits we want. This can also be done with dose resolution also. So after that, we want to do storage optimization, because unfortunately, these polymer gels do take quite a long time to store. And if we want to implement them in a clinical setting, we must take this into consideration. So the gels typically require about 24 hours post-fabrication of storage. This creates a uniform temperature and minimizes the temperature effects. And then it also requires approximately 24 to 48 hours post-irradiation to minimize the instability from continuing polymerization. This can be seen in figure 5, where we see the R2 dose response curve. And then about 24 hours later, we see a plateau, indicating that there's minimal polymerization compared to other times. So how we conduct this? This will be done using similar methods to the ratio optimizations. We will store gels for various amounts of times. I'm thinking about 6-hour intervals. And then the dose response sensitivity will be compared to the associated storage times, and I will create a storage time to sensitivity ratio. The storage time sensitivities will then be used to determine the optimal storage time required based on the clinical needs. So once we have our optimized dosimeters, our next objective would be to create a detailed fabrication procedure. This will be done by using easy to follow instructions and visual aids, set it in a manner that even the most inexperienced individual could follow. All chemicals involved in the fabrication will be extensively researched with the hazardous precautions clearly labeled to warn the fabricators. This procedure is extremely important, as we cannot assume that there is going to be a dedicated person with expert knowledge to make this gel each and every time we want to use it. Especially if you talk about routine usage. Therefore, having a detailed procedure would minimize any errors that occur when creating the gel, and also it would minimize inter-batch variation, which is extremely important when we're talking about dose distributions. And then finally, the last objective would be to make recommendations to establish a miniature laboratory within the hospital. So this would be done. So with the detailed procedure and knowledge gained throughout the project, recommendations will be made to the staff at Sir Charles Gardner Hospital. These recommendations will be based on the requirements of the safeties, the storage, and the practicality of polymer gel dosimeters. So for example, like if we need a waste disposal system, or the level of what type of gloves we would need, stuff like that. These recommendations will go into establishing a laboratory within Sir Charles Gardner Hospital, and if we can establish this will allow for the streamlined implementation of the gel dosimeters, because they'll be easy to make. We could store them at the hospital. So, and then finally, to summarize, I've got my research plan. So I'll just go over it again. So at the start, we've got the selection, and then that will be done by using a lit review, comparing all the different types of sensitivities and dose resolutions to determine which one we want for our clinical application. From there, we're going to be optimizing it, so changing the ratios of the composition. And then after that, we're going to try and optimize the storage, so we try and minimize time required whilst still keeping good sensitivity and dose resolution. From that, we're going to move on to the procedure. So we're going to have to do a hazard investigation of the chemicals used to make sure that we're following proper procedures, and then obviously writing the procedure. After that, we will send our recommendations to the hospital in order to establish a laboratory. And if all goes well, my final plan would be to implement it. And yeah, that's all for today, guys. Thank you so much for listening. Is there any questions?
Excellent. Thanks very much, John. Any questions from John? Rashid, you have a question?
John, that was very nice. Thank you. I was just concerned that you have a lot of things listed to do. Do you think you will have time to do all of that?
Yeah, so definitely there's a lot. Currently, we're working on objective 1 right now, literature review, and I am hoping to present possible gels to my supervisors. But yeah, there is a lot to do, and I am planning on working very hard. We are hoping to at least pick a gel and optimize it, definitely our procedure. If worse comes to worse, we might not be able to implement, but at least we'll have the background and know how to do it.
So are you using what Brendan has created?
We're unsure currently, so that is definitely one option. We want to look at the research done by that from the thesis, but we will be also exploring other options and weighing them all up together.
Okay, lovely. Thank you.
Any more questions?
Yes, we have more questions. Michael?
Hello.
Yes, thank you, Pejman. Thank you, Jonathan, for the talk. My question's about applications. So you're developing this for a clinical department. So my question is, do you know what applications Charles Gardner intend to use this for?
Yes.
And if you do, just second part of this question, how does the application actually affect or influence your project?
Yes, so from my understanding, we're going to want to do that more on an emergency basis. So like, and also I'm going to assume for like high conformal procedures. So basically the ability of the gel will allow for there to be a more accurate dose representation. And that would allow for obviously minimal errors in the within the treatment, so to increase the therapeutic window, obviously, and to overall improve the results of the treatment. Further applications that could be potentially used in Charles Gardner Hospital would potentially be for brachytherapy. There is a center in there is a brachy center in Charles Gardner Hospital, and the steep dose gradients that are measurable in the dosimeters could be used. But that's sorry.
Nothing. No, don't worry.
Thanks, Jonathan. So just second part of that question, how do those applications, how will they feed into your project and how you go about it, I guess?
Yeah, so my project won't necessarily be based on the applications. My project's more so of just providing the tool to be used for applications. So I'll mostly be just trying to get the job within the hospital so that the medical physicists and the oncologists could have that as an option.
Okay, so it's more a generic tool
Yes.
rather than a specific tool.
Yep. So as we don't have a job right now, I couldn't fully get into the applications. But once we've progressed through the project, hopefully it'll be more specific.
Great, thank you.
So one more application can be CyberKnife, John. It's very conformal methods and small fields. Okay, we have Tegan.
Hi, Tegan.
Yeah. Hey, Jonathan, thanks for that. It was very good.
Thank you.
Now, my question is about the temperatures at which you want to store them and versus irradiate them and how that impacts the polymerization time. So you did mention that you had to keep things stored for a while to try and make sure they're all the same temperature. And then also after you irradiated them, you had to store them again so that it had time to finish polymerization.
Yes.
And you said it was somewhere between 24 and 48 hours. Do you think that is, or is there evidence that that is strongly temperature dependent? Or is it more chemically dependent than temperature dependent?
So yeah, it is temperature dependent. We have noticed that with an increase in temperature, especially during scanning, there is actually a loss of sensitivity that has been noticed in almost. This is dependent. It's not. It also is dependent on the chemicals. So like each different gel has different dependencies. So some gels might be independent, while some gels will be highly dependent. That's going to be part of our objective one to determine which one we want. But there has been overall for majority of gels, there has been a negative effect of temperature. So by storing it and getting a uniform temperature, we won't have like certain regions showing less sensitivity, which could be interpreted as less dose, and for example. And in terms of polymerization and post-irradiation, again, decreasing the overall differences in polymerization that would be continuing would help to represent the true amount of dose in the gel.
Okay. All right. And when you talked about scanning in MRI,
yes.
So it would the reading have a difference as it warmed up during that, or would you be thinking fairly short sequences, so it's only out for a short amount of time?
For MRI, I'm not too certain, but for CT, definitely the warming up has a major impact. So I would assume also for MRI, but yes, so the CT does have a major impact. MRI, I'm not too sure about. I'm sure I could do a bit more research, find that one out for you.
Okay. Thanks, though.
Thank you so much.
Thanks very much. Mario.
Hey, Pejman. Now all good. I had actually the same question as Tegan, and John answered it nicely. Great presentation, John, by the way. Thank you
very much.
Thanks very much, Mario. All the best. There's no more questions I can say.
Thank you so much, guys.
Martin, if you can please